Yes, like that. Yeah. I'm gonna move to that day. Yeah.
Hi, Prof.
How are you?
Fine, thank you. How are you?
Good, thank you. Is Dr. Basura still there, or is he gone?
Just it's should come on now. Is it on?
Testing one, two.
There we go. That's much better.
Testing.
Yes. 1, 2, and here
And the audio?
While we're waiting for everybody to gather, shall I show you the case we're doing today? We have an interesting case.
Yes, sure.
Let's see if I can do it real quick. Well, maybe I'm not able. I think I have this figured out by now. Did Dr. Basura have a good week?
Hey, Brad, how you doing?
Good, how are you?
Yeah, doing well, doing well.
Are you back stateside, or are you still in the Southern Hemisphere?
No, I'm back. Yeah. Hey, guys. Yeah, that was great. It was great. Yeah, I went up to Zimbabwe and worked with Erasmus on his temporal bone course there, and then work with Lillian for a week in Cape Town. Yeah, it was fantastic.
Oh, wonderful.
Really good.
I was telling a quick image of the case we're doing this morning while everybody's getting loaded up. But since you're here, I'll quit showing it.
Oh, this is the case you're doing today? Oh, wow.
Patient today. And the interesting thing about this is she's had a little bit of unsteadiness for about 2 or 3 years. But the most curious part of this is check out her audiogram here.
Yeah, it's probably remarkably good, isn't it? It's probably, I'll bet it's like, yeah.
There's your audiogram.
Oh, yeah. Isn't that amazing? Yeah. And then you get these, half a centimeter tumors near the fundus there, and then they've got poor hearing. It's amazing. So are you doing a retrosigmoid debulking first and then see how it goes?
Yeah, that's the plan. That is the plan.
Yeah, probably staged. Yeah,
stage it. We'll probably take it all out today, but
it'll be a retrosig, really.
It's retrosig, yeah.
Wow. Even all that anterior component, huh? That way far anterior stuff, huh?
Yeah, there's not. I think we'll get it all out retrosig.
Yeah. Okay. Great. Yeah. Well, hopefully the hearing will. My experience. Do you do those in a decubitus or like a park bench type?
We just do them supine with their head turned. We don't put them in decubitus.
Oh, wow, that's nice.
Put them in pins, and unfortunately, her ABR is completely out. She doesn't really have any wave 5 with monitors, even though her hearing's so good. So.
Okay. Yeah. Wow. Yeah. My experience with this is that when they open the cistern on a retrosig, the tumor's kind of sitting in this buoyant CP angle cistern, and it falls the minute you take the fluid out. The tumor falls down in the angle and it praxes the nerve, and ABR is gone. So that's why those, yeah, I don't, that's why I'm always curious to see how other people do those because, to avoid that buoyancy factor, when the minute you suck out the cistern, there's nothing to hold that tumor up and then it,
Well,
yeah,
with them in a supine position, with their head turned, I don't
yeah,
feel like a
yeah,
drop. Just kind of it
that's
stays in.
nice. Well, yeah, yeah, that may make a difference. My neurosurgical colleague puts him in a decubus position. So that, yeah, I don't
Yeah.
know. Anyway,
Yeah.
yeah, well, good luck with that. Yeah, you have to let us know how that goes.
Yeah. All right. Well, I'll have
Yeah.
to sneak a minute and go say hi to the patient, but I'll
Oh,
be back.
sure. Yeah, no problem. Yeah, got it. Okay. All right, guys. Hey, Lillian, how you guys doing over there? Can you hear me okay?
Yes, if you fine.
Hey, Chevy, how you doing? I can see part of you guys. Got a full house today. All right. Look at this.
Yes.
All right. Excellent. Well, good. Well, today we're going to finish some chronic ear cases and then kind of pick up where we were last. Let me see where we're at here. Let me share my screen. Got going on here.
The temple bone course go well, Erasmus.
Oh yeah, it was great. Yeah, it went really well. Yeah, there was probably like 11 or so folks there, and yeah, it was really good. Yeah, about 2.5 days.
Nice.
Yeah, it was nice. Let's see. Okay, here we go. Okay, so let me just. Okay, so where we left these off last time, guys, we have a few cases to talk about. So we'll kind of go through these and then so is it Shavin, is it Divya, Lillian, and who else is there?
Yaku.
Okay, got it. So okay, great. All right, so we have a 58-year-old, progressive hearing loss, 4 to 5 years, no particular otalgia or urea, some fullness in the ear, which is oftentimes what patients will complain of, with progressive loss, and no associated vertigo. So what we'll do is maybe we'll start with Divya. Can you describe to your colleagues what you see here? First of all, tell me what year is it, and tell me everything you can see. If you were describing this over the phone to someone, tell me what you see.
Sure. So this is the right ear, and I can see that there's some debris collection in the pars flaccida in the attic. Not able to see, would need to suction to see what's the extent of it. But just by the first look of it, it's a attic disease retention in the pars flaccida. The tympanic pars tensa itself looks normal. There's a cone of light. There is some opacification in the posterior superior. Don't know if that's tympanosclerosis or maybe some cholesteatoma behind the tympanic membrane. Yes. And there's also the canal, the anterior wall of the canal is sort of narrow, like there's an overhang. So in terms of taking the patient, if we need to, if it's in my head, I think this could be a cholesteatoma. We need to see for a canaloplasty at the same time.
Okay. So on that, if you have the patient in the clinic chair, is there anything you'd want to do immediately while you
Yes,
have
I'd like
there?
I'd like to do a pneumatic otoscopy to see the mobility of the tympanic membrane.
Yep. Okay, that's good. Is there anything else you'd want to do?
Suction out the debris to see if there's what's behind.
Yeah.
In the
kind of that crust up near the attic, right? What might you expect to see? What are you expecting to see maybe if you remove that?
The cholesteatoma hiding behind granulation tissue, suction pocket. Yeah.
Yeah, yeah, exactly right. So yeah, so the key on this is you're right. So I would call that a kind of a prominent anterior canal wall hump there. Um, and as I was talking to Lillian this last week, the key to doing really good examinations is to be a mobile observer, right? So in the clinic, you want to be mobile. You want to be looking, swinging all around, looking up and down, because many times your line of sight is obstructed, and so you want to be able to move so that you can improve your line of sight. So you can kind of move more posterior in the patient, but again, this isn't really the anatomic location the patient would be position they would likely be in, right? Usually in the clinic, they'd be laying down typically, at least in my clinic, I'm laying back and I'm looking at their ear from a supine position, right? But it still gives you, you want to make sure you can move around that. And you're absolutely right. So the key is to remove that crust because you're expecting to see maybe a bony defect there. What part of the bone is that called right there?
The
Specifically,
scutum.
sputum,
Scutum.
right? Yeah, yeah. And then what would be, if the bone is eroded there, what structures do you expect to see if the bone is eroded there? If the scutum is partially eroded because of cholesteatoma, what space are you in and what structures are you expecting to see there?
Will be in the Prusak space and then
Mhm.
the head of the malleus.
Head of the malleus, right? You might see the malleus, right? That's right. That's right. Good. Okay. So yeah, and then that you mentioned it there. So how again did you know that this was a right ear versus a left ear?
It's from the handle of the malleus.
Yeah. Yeah. And also to just obviously, are there any other indications that might help you? Other
Like
things you might be looking for?
a cone of light,
Yeah,
anterior,
sometimes
inferior.
the cone of light, right? If it hasn't been operated on, for example, that's correct. Yeah, yeah. But you called it out. There's a whitish sort of mass maybe behind the posterior superior quadrant of the drum. Yeah, and obviously that's important, right? And that's the other reason why you want to do pneumatic otoscopy is that can also help you tell you, is that white, is that a plaque that's impregnated in the drum? Like, is it a tympano sclerotic sort of focus? Or is it separate from the drum? Many times you can tell that. Plus, also, it's good to help to see if there's fluid. That's also helpful. Okay. So when you do a tuning fork test, the bone conduction is greater than the air conduction in that side. So maybe let's ask one of your colleagues, Shavin, what do you think about that? What would that tell you if I did the Weber and it lateralizes to the right, and then the bone conduction is greater than air conduction? What does that tell you with maybe a 512 hertz fork? Without having the audiogram, what might you expect to see in that patient? First of all, if it lateralized to the right and you didn't have the test, if you didn't know about bone or air conduction, if it just lateralizes to the right, what kind of conclusions can you draw there?
Well, one, that you're not dealing with the video. And two,
I'm sorry, I can't quite hear you. Sorry.
oh, sorry.
Yeah, just come a little closer. Yeah, thanks a lot.
No, we're working from a laptop. Apologies.
Yeah, that's okay. Yeah, that's okay. So if it lateralizes to the right ear, and you haven't done bone or air conduction yet, what do you draw from that? What does that tell you, possibly?
So that you potentially have ossicular disease. You could also have a perforation behind that little.
Well, in general, not the cause, but what kind of hearing loss, or what would be the status of the patient? What general terms could you say about their hearing? Not necessarily what's causing the hearing, but what could you surmise about their hearing?
Oh, I understand.
Potentially having one ear versus the other ear if it just lateralizes to one side.
So that they've probably got a conductive hearing loss on the right side, or potentially a sensorineural hearing loss on the opposite side.
Right.
Or if you've got bilateral disease, at least you know that if the tuning fork goes to the right, that you're not dealing with a dead ear. That they've got some kind of hearing on that right side. So I think that's
yeah. So yeah, you're absolutely right. So if it goes to one side, you don't know, is that a Is it a conductive loss on that ipsilateral referring side, or is it a sensorineural loss on the contralateral side? So then if bone conduction is greater than air on the right, then what further conclusions can you draw from that?
The bone conduction is better on the right.
So it
Got a
lateralizes to the right ear,
conductive.
and then bone conduction on that side is greater than air conduction.
Or they've got a conductive hearing loss.
Right. And if you're using a 512 hertz fork, what can you give even more detail about maybe the level of the conductive loss?
I think it's 30, yeah, it is, yeah, 30 dB. But it potentially, yeah.
Yeah,
30
there's usually
dB.
maybe a range. Some people will say, I don't know, 20 to 30 maybe, but it tells you that may be what you expect. You'd have to have that level, right, for it to flip the fork, right, for the bone to be greater than air conduction with that frequency tuning fork. Okay. So, all right. So then, all right. So Lillian's in the background there. Lillian, what do you want to do next about this patient? Do you want to say, we'll give them some drops, send them on their way? Come on up. You guys are so far away today.
Yeah, I think we need to just all gather around.
You guys want to sit closer to the coffee pot. I get it. I understand. I see how it is. Sitting closer to the tea and the coffee, and I understand.
Very told
Thought
you,
I-
Prof.
You thought I wouldn't see you way in the back there. Yeah, yeah. I see everything. Just remember, I see everything. Kidding. No, so Lillian, so what do you think? So do you just tell the patient, okay, we'll take the crust away and put you on some drops, and we'll see you back in 6 months, maybe with repeat hearing tests, keep the ear dry. What do you want to do? How do you counsel this patient?
So for this patient, is first thing is I want to take the crust out, do some oral toilet, and make sure that I can see what is beyond the crust. If I'm able to clean out to the end of the retraction pocket, then I probably want to send them to audiology and ask them to do a hearing test, and also to do reflexes, tympanic reflexes. So I'd send for both a tympanogram with reflexes and an audiogram, and then I'll make a decision following those results.
Okay. Are reflexes a must? Is there a particular reason you need the reflexes? Is there anything you're thinking about with that, or why do you feel like you need that?
I want to do actually the thing that would make me want to do reflexes is that discoloration behind the eardrum, and I'm thinking about if there's a conductive hearing loss and there's maybe some tympanosclerosis behind a fixation of the ossicles, maybe. So, and I want to see the audiogram because I also want to see if there's any the pattern, if there's the eardrum is mobile or not, and that is what I'm looking at.
Okay. Okay.
Yeah.
Okay, so here's the audio. I don't have the rest of the details for you, but can somebody we'll go back to Divya. Divya, so tell me about this audiogram. Tell me what you see.
Yeah. So on the left, it's a normal hearing, while on the right, it's so over the low frequencies, it's a conductive, mild to moderate conductive hearing loss, rising up to
Is that mild? Is that a
moderate. So in all, it's a mixed hearing loss.
Mhm.
But over the lower frequencies, it's a moderate to severe sort of conductive hearing loss, rising to normal over the mid frequencies, and then again dropping to moderate hearing loss over the high frequencies.
Okay, Shavan, how would you say? How can you describe it? Do you agree with your colleague? What do you think? If you were describing that audio, what would you say? How would you describe the pure tone averages there?
So I think this is it's a mixed hearing loss, specifically in the lower
You guys are kind of away
frequencies.
from the mic. I'm sorry. You kind of muffled.
So if I look at it, it looks like a hearing loss.
You still, sorry, you're still a little muffled. Where's,
Wait here.
there you go. There you're back.
Okay.
Sorry,
So
sorry.
So this is so in the lower frequencies, I can see there's quite a large airbone gap, but it's a mixed, I would say it's severe, severe rising to normal mixed hearing loss so it's severe in the lower frequency, rising to in the mid frequencies, normal hearing. And then dropping off again from 4,000 hertz. That looks like also, yeah, that's a moderate hearing loss, 8,000 hertz.
Okay. So, Lillian, where do you divide up how do you define mild, moderate, severe, profound? What levels of pure tones do they have to achieve to have those descriptives?
So you want to define the hearing loss based on the pure tone average. So you take the average of 5, 1,000 and 2,000, you add them up, and then you can add those 4 and divide by 4, or add the first 3 and divide by 3 to get the pure tone average. So in this patient, this is a patient who has a mixed, first, the pattern of the audiogram is an inverted U, where you have a slope that is rising, that is, you have a loss in the low frequencies with a rising slope that is going to the higher frequencies with with a quite closing of the airborne gap at 2 kilohertz, and then a deep down at the higher frequencies towards the 8 kilohertz. So it's sort of like an inverted U kind of shape audiogram, meaning that there is a variance in the hearing loss. There's a mixed hearing loss with more of a conductive component in the lower frequencies. And then you have almost normal hearing loss in the mid frequencies. That is a speech frequencies, 1,000 to 4,000, and then high frequency loss.
So at any given frequency, so can you tell me, so if you just, instead of the pure tone averages, so for example,
the pure tone average,
so if you had any, right, so any specific frequency on the audiogram.
Okay, so
what range would they have to be mild? What would they have to be moderate, severe, profound?
Okay, so anything between 20 to 30 is a mild hearing loss. Then a moderate hearing loss will come in the 40 to 50 kind of 40 to 50 frequencies. Then between 60 to 80 you have a severe, and anything above 80 is a profound hearing loss.
Okay, yeah. Here I usually use 20 to 40 as mild, moderate's 40 to 70, 70 to 90 is severe, and then beyond 90 is profound. But yeah, I mean, there's probably a little bit of interpretation differences there depending on where you are. Yeah, but no, that's absolutely. So I think obviously here, this has got several types of hearing loss, right? So it's kind of it's a severe low frequency mixed loss, right? Rising. So when it returns to normal, it's rising versus falling. Rising to near normal mid frequency with some conductive component, right? It's very mild to normal. And then it slopes or falls to a moderate high frequency sensory neural loss. Yeah. So it's kind of an interesting audiogram there. But as Chauvin was saying, this could give you a flipping of the airbone gap, right, or the tuning fork, right, because of with the 512 hertz fork, right? So you may see that. So so the key is, there's you can predict a little bit on what the tuning fork is going to tell you when you get the audiogram, but obviously it's very important to see, always getting an audiogram on these, because you don't know the subjective nature of tuning forks can be challenging, right? Some people, you may do five tuning forks on the patient, you get five different sort of interpretations from the patient, right?
Yeah.
So the audiogram is really critical for that. Okay, so what's next then? So Lillian, I can stay with you on this one. So now you've got the audio, you have the physical exam. What's next? How do you want to proceed with this patient?
So with this kind of pattern, you're thinking of probably a patient who has autosclerosis or maybe tympanosclerosis.
So based on that physical, based on that physical exam,
based on
that
then,
exam and your audio, what do you thinking now? What's the next steps for this patient? What's your sort of working diagnosis, and then how do you want to counsel the patient?
So now based on this, I'm thinking that probably this is a patient who has eustachian tube issues with retraction pockets, and probably has some form of conductive hearing loss, either due to the chronic retractions with the ossicular chain pathology,
Okay.
possibly. And
Okay.
so, given that there's no otorrhea, there are two options. I still would insist on having a tympanogram to confirm the mobility or the status of the ossicular chain. And with that, then I would recommend possibly use of, because the hearing is still not really bad and there's no otorrhea. If I'm able to clean out the debris to the end of to see the end of the retraction pocket, then it's a patient that I would want to follow up in the clinic with annual audiograms and follow up and see and clean out. If I'm not able to see the end of the retraction pocket, or if the patient has a cholesteatoma visible or a bone defect in the attic, then it's a patient who I would want to do a CT scan, a HRCT, and follow up with the possibility of having to plan for surgery, depending on the results of the CT scan.
Okay. So, right. So let's say you remove the crust in the clinic and there's a scutal defect there. You're looking into Prussac space, you see the head of the malleus. So that's not just a retraction pocket, that's actually a bony defect or a scutal defect, right? When we talk about retraction pockets, that's usually in the drum itself, right? There's a retraction of the drum. This is an erosion of the bony scutal. This is a scutal defect. So it's not really a retraction pocket. That's actually bone that's been eroded. So you remove the crust, which is critical in the clinic, right? And then you see squamous debris in the Prussac space and bony erosion. So does that change? What do you want to do now?
Then you want to ask the patient to do a CT scan, a HRCT for the temporal bone.
Mm-hmm. Okay. I have to ask you a question is, what if they didn't have this scutal defect and that area was fine, and all you had was this whitish mass in the posterior superior quadrant with that audiogram? What would you do then?
I would still ask for the CT scan because of the whitish mass and the defect. Yeah.
Okay. So what would I'll ask Divya or Shavin, what would you say? So if they've never had surgery, there's never been an otorrhea, let's say you don't have a scutal defect or a crust there, you just have the whitish mass behind the drum. What could that primarily be?
So it's either cholesteatoma or it could be tympanosclerosis.
Okay. How could it be a cholesteatoma if they've never had surgery or perforation of the drum or something like that?
It could be
Sorry, Divya,
congenital.
you're a little bit away from the microphone. Can you slide to your left a little bit?
It could be a congenital cholesteatoma.
Yeah, congenital, right? Yeah, exactly, right? So congenital cholesteatomas can form. And, how does that happen? Anybody?
In the embryonic stage, there are some cell rests that get stuck behind.
Sorry, you're still a little away from the mic. I'm sorry, that's very sensitive with the microphone. I think you have to get.
So in the
That's better.
embryonic,
That's better.
yeah, in the
Thanks.
embryonic phase, there's some cell rests
Yeah.
that gets left behind.
Yeah, they
The
get
ears.
trapped rest
They get
cells. Yeah, exactly right. You got it. Good. Okay, good. Excellent. Okay. So you guys wanted to CT. Okay. All right. So who's going to interpret the CTs for me?
I can. Okay. Okay. Yeah. Cool.
Yeah.
Yeah. Well, put him on the hot seat. Here we go.
So on the on the top image, looks like a coronal section,
Uh-huh.
where I can see some debris in Brussac space, with erosion of a scutum, and also looks like there's some erosion at the base of the skull as well.
What's that area called?
A tegmen.
What tegmen specifically? What part of the tegmen?
I think tegmen tympani.
Okay, good. Yep.
It's not 100% clear from this if there's erosion of this ossicle.
Mm-hmm.
I would presume it would be eroded since the skin.
You said the coronal image on the top. What level? So it's always important to say, is that contrasted or non-contrasted, and what levels within the coronal imaging are you at? Always important to orient.
So I would say uncontrasted because I don't see any vessels full of contrast on this. And then level, I'm not sure how to describe the level.
Yeah, what other structures do you see adjacent in the temporal bone that might give you, they can tell you where you are? Do you see any other structures that you recognize?
I can see the apical turn of a cochlea.
Uh-huh. Yeah.
I can see the middle ear cavity, and I can see the external auditory canal full.
And is there a structure? What's that structure below the cochlea? A little gray thumb-like structure that's pushing up toward the cochlea. Any idea what that is?
The jugular bulb.
No.
Carotid, exactly. Okay, good. Yeah, okay. All right. And all right, let's talk a little bit about the bottom series. What do you see in there? Can you describe that?
So that's an axial image, where I can see posteriorly some mastoid air cells. Looks well aerated.
And again, what's the level? Can you describe any other structures you see there? So you don't want to say this is a non-contrasted axial view of the temporal bone at the level of the
lateral semicircular canal.
Yeah, right. And then to the right of that, medially, what do you see in there? Medial to the lateral canal. It's not the external auditory canal, but the
internal auditory canal.
Internal auditory canal. There you go. Good. So always orient. So if you're getting an oral exam, that way the reviewer knows what levels you're at. It's really important to orient that first. Okay, so go ahead.
So then I can see, I don't see any opacification of the mastoid air cells, but I can see some opacification of the middle ear. But the opacification extends into the actus antrum. And then I do see ossicles, and it does look, I don't see the classic ice cream cone configuration there. So I'm not sure if that signifies erosion of an incus, possibly.
Okay. Yeah, good. Yeah. So a couple things is, so Divya, how do you know, if you just saw that scan, would you say that is 100% absolute cholesteatoma? And if so, how do you know?
So cholesteatoma is more of a clinical diagnosis. So I'd go with the clinical picture and the scan and the audio. Yeah, not
Mhm.
only
Right.
by.
So yeah. So he called it debris. How do you know it's debris? Or would you describe what you're seeing differently? How would you describe it?
The scan? Oh,
Yeah, no, what he described as debris, do you agree with that description?
oh,
How do you know
oh,
it's debris, or would you describe it differently?
oh, yeah, I would say soft tissue density because I don't know what it is.
That's exactly right. You have to be careful about the wording you use, right? So yeah, so it's basically a soft tissue density, right? It could be chewing gum, it could be a raisin, it could be a cotton tip applicator, it could be, wax, it could be, who knows, right? So you have to use CT in the clinical context of what you're seeing clinically, right? Exactly right. So you can't now. There are features consistent with an erosive process, which a cholesteatoma is, right? And as he said, absolutely, is there scutal erosion? There may be a small defect in tegmen tympani, right? The acicular chain may be looks a little abnormal in the axial view there, potentially. Yeah, but you're absolutely right. So I'm trying to make sure you use the correct terminologies when someone's sitting across from you saying, so tell me about this film. So always orient first. What view are you looking at? Is it contrast or not? What level are you at? And in the mastoid, we'd say that's a well pneumatized, well aerated mastoid, right? Always talk about the relative pneumatization and aeration of a mastoid. That's really important, right? That has a lot to do with the clinical context, the functional context. It has a lot to do with maybe the pathology that you're evaluating. Exactly. Okay. And then other things too is that, so it's going from essentially it's extending from the middle ear into the antrum, right? It's effacing the horizontal canal dome, but it doesn't look like it's eroded, at least at that level, right? Okay. All right. So Shavin, you're next up. So what do you think? So you got this scan. She's still there.
Shavina. Yeah,
Shavina.
Shavina.
Sorry,
Yeah,
Shavina.
yeah.
Sorry. Shavina.
Okay.
So you're next up. So what do you think about this? So now you are going to so now you have a clinical exam, you have an audio, you have a CT. And I'm your patient. So tell me what I have and what are you going to do? What would be the next steps?
So I'd explain to the patient that, it's not just retraction pockets that we're seeing. There's actual erosion of the scutum, potentially even erosion of the tegmen as well. So it's an unsafe ear. And if I can't clean out, you can't actually clean that out in clinic. So the patient would need surgery. So I would
So
chat to
first you're
them
going to tell the
about,
patient, what do they have? What's the diagnosis?
well, they've got attic disease. And
Attic disease, what does that mean? Like, doc, what does that mean? Like, when you say I have attic disease, what does that mean? Does it mean I have like a cold, like I've got an infection? Well, what is the actual diagnosis?
yeah, so I think, if I saw a squamous debris in the clinic and with this scan, I would say that they've got a cholesteatoma.
Cholesteatoma, correct. Yeah,
yeah.
that's the diagnosis, right? So they've got likely an attic cholesteatoma.
Yeah.
That now on the film, you have some extension toward the mastoid antrum. Exactly right. So that's the first thing I say. So you have a cholesteatoma, right? And then
Yeah.
is that a medical disease or is that a surgical disease?
It's a surgical disease.
Right.
So
Yeah.
it's
So you want to be that frank with the patient. Say, listen, you have a cholesteatoma. This is basically skin that's in the wrong place, skin that gets trapped in the wrong places of the ear. And unfortunately, it releases enzymes that break down bone. So this is an erosive, benign disease, but it can become very serious. So you want to use very simple language with patients. Say exactly that. This is a surgical problem. It's benign. It's not cancer. It's a skin tumor, but it's not cancer. You got to really tell people that if you use the word tumor, they need to know right off the bat, it's not cancer, right? But it's erosive and it can create all kinds of problems. So you have to tell them about the serious nature of it, because when people hear skin, they may think, well, then this isn't a big deal. Why do you have to operate on that? What's the big deal? Just leave it alone. So you have to be very clear about that. So that you've said that. So then what specific types of intervention, if it's a surgical problem, can you explain to them or to me, what are you going to do?
Well, you need to clear the disease and clear out all that squamous debris,
Okay.
and make it safe again. So they would require, at the very least, an atocotomy. So we would sort of, if I have to explain to the patient, I would have to go into your middle ear space, usually through a postauricular incision, and actually go and clear out and drill out that bone to make sure that there is no squamous debris left. Also, if there's a defect in the tegment, that also needs to be addressed. And if there's ossicular, looks at on the axial view, that there might be some ossicular erosion there, that it may be even, so you could either do it as single stage or a two-stage procedure, where the patient may or may not need an ossiculoplasty as well, depending on the extent of the disease at the time of the surgery. And then obviously you need to explain to the patient that sometimes sometimes you have to leave disease behind, especially if it's on the dehiscent facial nerve, or it's sitting around the stapes foot plate. Then you would tell them that you may need to go back, and that the surgery may be more extensive than it depends on what we find as well. So also tell them it's more also like an explorative surgery, because if you have to follow the sac, you might end up doing more than just an atocotomy. Depending on the progression of the disease, you may actually have to do a front to back, or the whole mastoid. But for the moment now, based on the scan and what we see in clinic, it wouldn't be as an extensive surgery as a front to back. But yeah, you need to address the attic disease and potentially the ossicles as well.
So Doc, I don't understand when you say a front to back. What do you mean by a front to back? Does that mean you're going to take the front of my face all the way to the back of my head off? When I don't know, when you say front to back, what's a front to back mean?
So essentially, it's following the disease, so normally a typical mastoidectomy is where you remove all the air cells that you see in the mastoid. So you drill them all down flat, and then you've got this big cavity that you can either try and build up and make smaller, what we call obliterate. But if you do a front to back, it's essentially, so you.
When you say front to back, I'm sorry, I know what you mean, but I'm the patient.
Yeah,
I'm the patient. So
Yeah.
I'm trying to drive home at a point here is you want to use very common language with patients. When you say front to back, front of what? To the back of what? What does that mean? When you say front to back, where's the front? Where's the back? What back of what? Reference to what? What does that mean?
So
Try to explain it to me. I know this sounds like a painful exercise, but my whole point of this is, as patients, the temporal bone is a complicated place.
yeah.
And it's so important to explain to them in detail in a very constructive but simple way about exactly what you're going to do, so that they understand. And I'll tell you a few things that I say, how I say it, just to put it in simple terms. But tell me more detail, like what does that mean when you say front to back? Like what is it that I'm expecting as a patient for you that you're going to do to me potentially?
So you'll still have the same incision. We'll still do a postauricular incision. We're still going to be drilling out the mastoid air cells and the bone at the back here. So we'll still be doing that. But whether we drill out the entire sort of mastoid air cell system that you've got, which is a bit more extensive, versus just a small area where just the cholesteatoma sac sits. So we limit the surgery. But as a patient, you tell them you're essentially following the disease. You're following the cells where the little sac of skin cells goes, and sort of clearing out those structures
Okay.
Yeah. But you'd still have the same incision. It's just, I would say for us as the surgeon, we would decide, if it's just going to be a small little cavity versus a larger cavity, whether or not we're going to keep, your canal wall up or down, because
There you
that will
go.
depend
See,
on
there you go.
your
That's what I was trying to
ability
get at is,
oh, sorry.
yeah, it's
Sorry.
yeah, intact
Yeah.
canal wall versus canal wall down, right?
Yeah.
That's
whether or not
probably a
that
better, that's, people can understand that because when you say front to back, you're talking about with reference to the canal wall, right? So it's really important to use those terms. What I say is two things. Okay, so with cholesteatoma, it's a surgical problem. Okay, there's two approaches to it. One is to extirpate. Extirpate means remove, right? So I'm going to do one of two E words, the E words. One is to extirpate, which means I'm going to work through the various compartments of the temporal bone to try to get the skin out. I got to get all the skin out. And sometimes the ear bones have to come with that we may have to rebuild later or at the time of. I may have to rebuild part of your eardrum at that same time as well. If I can't get all the skin out, I can't extirpate or remove it and retain as much anatomy as possible, I might have to go the other E word, which is exteriorize. I have to exteriorize the whole area, meaning now I have to open the whole area so that skin can't be trapped. If I can't get it all out, if I can't extirpate the disease, I'm forced to exteriorize the disease, meaning now I know I'm going to leave some disease behind, but now it can't be trapped. Okay. And so it's still a hard thing for patients to understand. So the funny analogy I use with patients is this. I say that pretend your temporal bone is like your house, okay? And you come home from work and the police are there and they say you have a burglar in the house. And they're gonna okay, we're gonna go in and find the burglar, okay? So to get the burglar out, the burglar is the cholesteatoma in the house, in your ear. To get that burglar out, they have to go through every room in the house to get it out, right? They got to look at the hall closet, the bathroom, the upstairs, the basement, the attic. They got it. That's the extirpate. You got to look everywhere to get that out. Well, let's say a couple weeks later, the burglar is back, or there's more than one, and you just keep getting robbed, and it keeps coming back. Okay, well, then you finally say, okay, I can't take this anymore. So now you tell the contractor, okay, I want every room in this house taken down. I want every wall in this house taken down. So when I walk in the front door of my house, I've turned the house into a studio apartment. I can see from the wall to wall, ceiling to floor, burglars right there. There's no place for the burglar to hide. Okay, so I tell the patients, I'm going to turn your ear into a studio apartment. Does that make sense? When I say it like that, patients are like, oh, that makes a lot of sense. So now there's no place. The minute you walk in that front door, burglar's right there. There's no room to hide anymore. There's no place to hide. They have to come out. They got to come out.
The reason Dr. Basura knows this is because where he lives in Michigan, that often happens. So he thinks of these kind of analogies.
That's exactly it. Tired of getting robbed. Exactly. They keep stealing all of our Michigan national championship trophies. That's a problem. I can't.
Yeah.
So, but the point of that is that I've learned after all these years of doing this that no matter how I was explaining it, patients were still not quite understanding that. And so I had to come up with some very common language analogy. I would encourage you to do that just because, when you start saying wall up, wall down, front to back, mastectomies, they still aren't going to get it because it's littered with a lot of jargon and things like that. So you have to use some real world examples like this that I think people sort of then they can understand it. Because, if you take the canal down and you exteriorize the studio apartment thing, they have to understand why they have to come back and see you, right? Like, well, wait, I thought I've had surgery. Why do I have to come back and see you? Well, now you're going to have I have to service the studio apartment. I got to send the cleaning crew in there to clean it up. It's going to have stuff in there. I got to make sure it gets out. So I think it's really important to, I can't overstate the counseling part of this. It's so important to counsel patients about what's going on. And that's, I think, the thing that takes probably the most amount of time is you can get the diagnosis, you can see clinically, you get the audio, you get the CT, you can make the diagnosis, and you can tell them all these, but it's the counseling part, the expectations, the hearing, the recon, the servicing of mastoid bowls, all these things that I think requires a lot of time. Yeah. So that's just,
ask
yeah,
a question.
Brad, go ahead.
Do you ever judge whether or not you'll take a canal wall down or leave it up based on the reliability of the patient, you know, and whether or not they'll return and follow up or not?
Absolutely. Yeah. I mean, I do. And I was just going to talk to the group about that, because if there's a worry at all, like, so in this case example here, this one, you probably could, this doesn't look, you know, and again, oftentimes I've been, you know, duped in the OR where you look in the CT and go, oh, that's not going to be too bad. And then you wind up needing more than the CT indicated. I consent everyone for a possible wall down. I really do, because I've been in the OR several times when I needed to do that and I hadn't consented them. So I had to stop. I couldn't do it. I had to wake them up and then take them back. So one of the things that Dr. Welling is talking about is, you know, there's an issue here is if the patient's not going to come back after you've done say an intact canal wall, temp mastoid, you know, there's a high likelihood of, there's about a 25% recurrence rate in those patients, right? The literature will suggest it's about 25% of those patients, 1 in 4 will probably have a recurrence. And if the patient leaves your office or leaves the OR thinking, oh, you know, I've had surgery, I'm good, I don't need to come back, then it's kind of like a little ticking clock in there. They may be one of the 25% that has a recurrence, and then that can lead to problems over time because they may just neglect that and think that everything is fine. So if there's any concern that they may not come back and see you, or they say, you know, I'm moving out of the country, I'm going to be in somewhere that I'll have limited access to care, that's something you have to consider when you're performing the surgery is, do you take the canal down? Do you exteriorize the disease so that they have a safe ear, so that they don't get a trapped issue and then get something, you know, eroding into the inner ear, God forbid, into the posterior fossa, getting a brain abscess, et cetera, et cetera. Yeah. And that may be really important in your practices, right? Where you think about this is you may never see the patient again. So the idea is, I got to take the canal down and exteriorize this to make it safe. Yeah. So
one comment about that. I think that many times we equate in our minds the idea that their hearing is going to be adversely affected by taking the canal wall down. But in a large study, a retrospective study we did a number of years ago, we found that the average hearing in a canal wall down as opposed to a canal wall up cholesteatoma mastoid was actually 1.5 decibels poorer in the canal wall down. Really not clinically significant. And so that could speak to the fact that some people with canal wall ups don't have good ossicular chain reconstruction, or it could be that people with canal wall down still have a potential for good conduction, but overall, there's not a great deal of difference in the hearing between canal wall up and canal wall down. So that probably should be factored in when you're thinking about the safest way to treat a patient, that you're not necessarily confining them to having worse hearing by taking their canal wall down.
Yeah, absolutely. No, it's a great point. Yeah. So, yeah. So what do you guys think about that? Comments? I mean, so Lillian, how would you have counseled the patient about this? So with this, how would you describe the surgery to the patient?
Okay, so the surgery for this patient would ideally be an artichotomy, where you want to, because this cholesteatoma looks like it's limited to the attic. And so what I would tell the patient is, one, we would want to give them, initially we would start by giving them a canaloplasty because of the blunting of the anterior edge. Thinking about follow-up, we would want to have a wide canal that is with a visible tympanic membrane. After that, we would open the upper part or where the disease is limited, which is the attic, which is the upper part of the eardrum, where the bone has a defect, and clean out all the squamous debris as much as to the end. If we find any defect, then at that point, there's the option of reconstructing or reconstructing any defect, especially on the tegmen, and also reconstructing to close off that area so that we can make sure that the debris does not recur again, and then leaving the eardrum. I would also mention the fact that there's a possibility that there could be, in the process of surgery, the eardrum might be damaged, and so there's a possibility that we might have to also do a tympanoplasty. That is, a myoplasty. So, and also the possibility of having to, we will also have, once we reconstruct the attic defect, that will close off it will close off the antrum. So that one, I would already have told them about. During the reconstruction, we will isolate the two spaces and leave the mastoid behind and the antrum. And yeah, then, so the possibility of having to reconstruct the eardrum, the possibility of also having put down the posterior canal wall is also something that you mentioned. And obviously, because this is a patient who had normal hearing, it would also be important to let them know that because we'll be operating in that ear, the outcome of hearing might change. So the hearing might decrease initially, maybe because of the packing of the ear, and then it improves, but we will expect, or we will follow up with an audiogram after 4 months once the ear is healed to see the outcome of the hearing. So I would also mention the effect of surgery on hearing.
Okay. Brad, do you stage these surgeries? If you had to take the parthesicular chain, would you rebuild the chain at the same setting, or would you stage, come back as a second look?
So it would actually.
Oh, I was sorry, Lily. I'm sorry. I was going to let Brad comment real quick, and I'll come back to you. Sorry about that. Apologize.
Go ahead, Lily. That's okay. I'll answer after you. Go ahead. You can answer first.
Would you stage surgery, or would you rebuild everything at the same setting?
The staging of the surgery would be dependent on the state of the middle ear intraoperatively. So sometimes you find that there's a lot of granulation tissue with a lot of infection, and you're not able to clean out all the squamous debris. In that case, you want to stage out your surgery. But if you're able to clean out everything and you're happy with the results, then you can do the reconstruction in the same city.
Let me make two comments about that. Often with cholesteatoma, there is a lot of granulation. There may be some chronic mastoid disease. This mastoid doesn't look so bad, but sometimes there will be chronic mastoiditis as well as the cholesteatoma. And one of the things that I like to attempt to do is when we begin the procedure, to lift the eardrum, take away the bulk of the disease in the middle ear, granulation or cholesteatoma, except for maybe the remnant that's right down on the stapes or delicate parts. Maybe there's a dehiscent facial nerve, or you might want to leave that, but clear away 90% or 95% of the infected disease in the middle ear, pack the middle ear with adrenaline-soaked gel foam, go back and do the mastoidectomy, come up into the attic and finish the cholesteatoma removal. And then when you go back in the middle ear, it should be much cleaner and drier, so you can finish removing the disease that's evident. That being said, I tend to, in my early practice, I would tend to stage things and leave the ossicular chain unreconstructed. Now I go ahead and reconstruct them at the same time because I feel that there's a chance that the ossicular chain reconstruction may not be perfect, and it may be that I don't close the air bone gap completely. And in 6 months, if I want to go back and reclose that or tweak it, I can. Or we can check again with a CAT scan and see if there's any recurrent disease. MRI scans are very good nowadays at detecting cholesteatoma with diffusion weighted imaging. And so I don't routinely plan for a second look as I used to. I prefer to try to reconstruct their hearing if it turns out that their hearing is good and their air bone gap closure is nearly complete. And on imaging, we don't see any recurrence, and I don't go back in and look. So I tend to do primary reconstruction. The other side of that coin is that some people feel, well, if you don't reconstruct their hearing, then they'll be sure and come back for their 6-month follow-up because they want to get their hearing reconstructed. And I suppose there's some motivation there, but I generally err on the side of going ahead and reconstructing them. And then if we need to tweak the hearing a little bit as the new eardrum settles in, we could do that 6 months or a year down the road. And also do a second look at that time. But if the hearing's good, I don't operate to find out if there's recurrent cholesteatoma, image them now.
Yeah. Great. Yeah. Yeah. So you see there's a lot of different ways to do it. So there's a lot of intraoperative decision making, depending on what you see and you know, patient dynamics, social issues, etc. Yeah. Yeah, that's good. Okay. So we're almost out of time for this one, guys. Sorry. I know we'll finish this one up next week if that's okay. Sorry, I know these take a while to talk about, but I think it's important though to talk about some of the nuance of these cases because, like I said, I think it's so important to explain to patients in a very clear, concise way what they have, what the importance of that is, you know, the plan, the risk benefits, all the things that you may need to do. So take your time with these folks. I think chronic ear disease is a challenge, not just surgically, but the entire process is challenging. Yeah.
Can I just make one other comment or observation? I know that you had mentioned pneumatic otoscopy because you can lift the drum and see if that is cholesteatoma in the posterior superior quadrant or not. I agree with that. If it's tympanosclerosis, it moves with the drum. If it's cholesteatoma, the drum will lift up off it a little bit. The other thing is that the eardrum's a little bit amber, and I wouldn't be surprised if there's an air fluid level in there. And you can tell that also by moving the drum. If you can get a pneumatic seal and move the eardrum back and forth, you can tell if there's actually kind of fluid in the middle ear as well. The last thing I just want to point out is that when there's an attic cholesteatoma like this, it's possible that there's not a lot of erosion around it, and you can just pull the cholesteatoma out of there. I have a nurse who works in our recovery room that I see every 6 months and take a little skin out of her attic retraction. But this case, you can see a little bit of redness, and when there starts to be granulation of the bone, you know it's eroded, and you can see anteriorly that there's a little bit of redness. I bet that if you take some of that cholesteatoma out, you'll see granulation under it, which means bone is being eroded. And I think that, you know, just looking at this, I'd say, yeah, you need to do surgery on this. This is not something you're going to fix with periodic office cleaning of the attic. So anyway, those are a couple thoughts I had about the physical exam.
Yeah. Thank you, Brad. Erasmus, you're still on the call. Thanks for joining us. Any thoughts on any pearls of wisdom you can impart? You're still there? There he is. Hey.
Hi, Greg. Hi, Prof.
How
How
are
are
you?
you?
I know you kept your camera off, so I wouldn't call on you. I know what's going on.
No, I'm good, thanks. How are you, Sabrina?
I know what's going
How
on.
are you?
Yeah, I got you figured out. I know what's going on.
I have a for Erasmus or for the folks in Cape Town as well. is follow-up difficult? I mean, I guess it depends on where the patient's coming from and so forth, if they live nearby, but do you find that you get some patients who come from quite a distance where routine follow-up is not easy to coordinate? How does that work? Erasmus, how about?
Yes, I think I have a couple of patients who travel 500, 600 kilometers to come and get an ear operation, and they go back. So those kind of patients, most of them, they don't come back for return follow-ups. So I think I tend to do more of an open approaches, I think. But yeah. Then yeah, I think the other thing that I just wanted to comment was if you see a crust of wax, I think in that area there, I think always have cholesteatoma at the back of your mind, and also be also sensitive. Sometimes it's very, very painful for patients if you want to try and scrape it off. So if you see wax that is stuck in that area, there in the superior area, I think always have a cholesteatoma at the back of your mind.
Mm-hmm.
Yeah.
And Lillian, in Kenya, then, do you think that exteriorization is used, to address Dr. Welling's question? Just worry about lack of follow-up, that patients may not come back, so you want to make them have safer ears and just have everything exteriorized?
Yes, definitely. It applies also for the patients who come from far, and the ones who have little or no access, also because we don't have ENT surgeons who can follow up in the periphery. And so you would want to give the patient the most and exteriorize as much as you can in most patients.
Greg, sometime it'd be nice to talk about canaloplasties for canal wall down and how different techniques, because I think when you're worried about that, when you know that people are not going to be able to get back for routine follow-up, there are some techniques for canaloplasty that are maybe more likely to be helpful. And I mean, you don't want to get a tiny canal opening with a large mastoid cavity in a canal wall down, and there's some ways surgically to work on that. Maybe that'd be a good topic to throw in sometime.
Yeah. Lily and I chatted about that this week a bit when we were in the lab, but yeah, we'll definitely hit that at the end of this segment too. We've got a couple more cases to go.
Right.
Sorry, I was hoping to get through the rest of the chronic ear cases, but you can see these are important. It's important to talk about all these nuances. It's not just, hope that makes sense. Yeah. Great. Well, thank you guys for being on the call.
I have a question. So for a case like this one that we were discussing, would you just go ahead and do an ear operation on them without doing a CT scan first? Like if you are in a resource limited area, would you just consider saying, okay, I will just go and open and try to see what am I dealing with?
Yeah, I think you would, Erasmus. I mean, if obviously clinically, this is, if you remove that crust and you see large scutal defect with squame, entering into the attic, I think, you would just, obviously you've got surgical indication right there. The only issue is you'd have to consent that patient for probably a lot of things, because you wouldn't know the extent of that disease. How far back is it going? Clearly, a lot of disease that's in the posterior superior quadrant, we know it's going to work its way toward the antrum. It's not a hard and fast rule, but some of the anatomy of the ear, if you've got an anterior superior quadrant cholesteatoma, many times that'll work inferiorly in the mesotympanum and then back towards sinus tympani. But those in the posterior superior quadrant, they want to go back toward the antrum. So you don't know, is there an effaced horizontal dome? Is there a partial fistula? So you probably have to consent them maybe for a canal wall down procedure. Okay. I would consent them for, if you don't have a scan, you'd want to consent them for a lot of things that would include wall up, wall down, circular chain reconstruction.
But I agree completely with Greg that you could take him to the operating room and just put all those things intraoperatively, just being careful.
Right.
So
you could have Tegman defects too, Erasmus. So that's the other consideration too. You might have large Tegman tympani, even Tegman mastoideum skull-base defects, you know, those kinds of things. Kind of like your case you presented on the society, you know, when you had an encephalocele, right? You know, kind of thing. So, yeah, there's a lot that, boy, some of these ears can look so innocent, and then you get a scan and like, oh, wow, it's amazing. There's a lot going on that just didn't manifest itself externally, but it's all been, it's, you know, internalized within the mastoid or even the temporal bone. Yeah.
Good to see you all this afternoon. I got to
Hey,
jump off.
Sounds
Thanks so
good,
much.
Brad. Hey, thanks a lot. Good luck with your case. Let us
Thank you
know
very
how.
much.
Yeah. Lillian and Rasmus, can you guys stay on the line for just a second? So Lillian, quick thing. I wanted to share with 1 second. Let me stop my share here. Okay. Well, I've got you on the phone. Give me 1 second. Lillian, the temporal bone course here is September 9th through the 13th. And then not again until October 14. So Academy will be sort of in between there. It won't be at that next like week on either side, unfortunately, here. So I just wanted to let you know that. Yeah, because the Academy is the 29th through the 2nd, I believe, October.
Yeah.
I mean, September.
Yes,
Yeah.
29th September to 2nd October.
Yeah, and so we have a temporal bone course that's 3 weeks before then, at least 2 weeks before then, and then it's at least it's 2 weeks after that. So it unfortunately doesn't abut right next to that. So we'll have to figure that out for next spring or something. Just wanted to let you know that. Yeah. So yeah. Okay. And then Erasmus, we were gonna for our next African Otologic Society meeting, I was gonna send you an email, maybe having you and Doreen maybe help with the co-hosting of that. Would you be available to help on that?
Sure. I think I should be available. It's towards the 20s, right?
It's gonna be the 25th, yeah, of May. I'm sending the email out this weekend with the agenda and everything. But you know, I don't know if you'd be available, you and maybe Doreen, maybe just maybe co-host a little bit on that. We can start.
Okay, sure.
Some of that kind of dynamic, if that's possible. That'd be helpful. Yeah, I'll send a more detailed email out, but yeah. Yeah, well, great. Well, thanks, guys. I appreciate it. We'll see you next week. So next week we'll do, and Shavina, Divya, thanks a lot for being on call. Sorry to pick on you guys, but I think it's, you know, it's good to vocalize a lot of these things, right? It's easy to think, you know, it's harder than you think to explain some of this stuff, isn't it?
Yeah.
Right.
It is.
So you might want to just practice on each other. Sometimes just sit down with a scan and say, okay, walk me through the scan. Tell me about what you see. You know, get used to the language, used to the rhythm of how you present that. Then when you actually do it, it's kind of like not autopilot, but you have like a pattern or a routine, which would be really nice. It takes a little bit of the pressure off, because if you systematically explain it and you get into a pattern of how you do it, it'll be a little bit more automatic.
Yeah.
So
Thanks, Prof.
Well, great. Well, have a nice weekend, guys. We'll see you soon.
You too.
Bye.
Thank you.
Bye.
Thanks a lot. Take care.
Hi,
Bye, Rasmus.
Shavina.
Be good, guys. Take care. Thanks a lot.
How are you guys?
Oh, we're fine. How are
Good to
you?
see you. Good to see. How is Lillian?
You're fine. Is that a microscope or are you at the gym?
No, I'm in my clinic.
No, I thought that was a thing that you were.
I'm in my clinic here.
Oh, everything's hanging. Okay.
Yeah,
Very
yeah.
fancy.
Yeah. I have a simple question, guys. What happened to your camera and your microscope, the Polycom one, that one?
This computer here is not working. This one. It's
I
not
can
working.
I can donate one for you guys from Zimbabwe.
Oh, you can donate.
Oh,
one.
okay. That's big talk.
Oh, you can donate one.
The problem is
Just-
after the
just-
update, it just
Just
died.
let the chief reg talk to me nicely, then I can donate one.
Gift is actually coming.
Sorry?
Gift is coming to Zimbabwe, so you can come with it.
Yeah,
Come
I'll give him the runs. Not an issue. I'll give him the runs. Anyway, good
Yeah,
to
I
see
think
you.
we lost it for a bit, Erasmus. We couldn't find the little speaker.
And then, yeah, Taslim was not happy. But we found it. We found it in a box. So we know where it is. It's just a matter of connecting it. But sometimes it works and sometimes it doesn't. I don't know. I'm not tech savvy, so I have no idea sometimes. So I don't know. I struggle with this polycam. It's just too, it's not Apple.
Okay.
It's not intuitive.
Another question, Erasmus. The case report.
Mhm.
Is
When,
there any?
I'll have to check on my, to be honest, I'll have to check on my laptop.
You forgot.
Yeah.
Actually, I forgot. When he does that, it's like, I forgot. I'm gonna bullshit my way through this.
I don't know, Prof. Harris said, you know, he's done it to
When I came back from Cape Town, I started on a fresh page and I left all Cape Town stuff behind. So I'll check on my laptop.
Well, Prof. Harris told Professor Pia Shazia that you have done 80% of it. So
80% of the
I need
study.
to finish 20%. And I'm under a lot of pressure, you can imagine. So please, if there's something, let me know. If there's nothing, yeah, the earlier the better. So we build on something.
So I'll give you one tip, Lillian. You know,
Yes.
don't let those guys pressurize you. I just absorb the pressure.
Say that. Okay.
Erasmus was the fella that was good at saying no.
Ah.
He was very comfortable.
I tried to say no. I tried to say no, but we have to finish the pending work.
Yeah. Okay. No, I'll check. I think over the weekend and see what information I have.
Guys think you're not sincere.
No, you look. You forgot, but you look now.
Okay.
No. That's a sincere look. You'll look.
Okay. Enjoy your weekend.
Enjoy your weekend too, guys. Bye. Good to see you.
Nice seeing you, Erasmus. Keep well. Bye.
Bye.